Dr. Amit, a few words from you, then maybe we can start.
Yeah, good evening, everyone. This is an initiative by ISA Delhi that we have started academic series. The first session was on 13th of the last month. That was on pre-anesthetic checkup, and it was attended by more than 100 people. And I'm sure that this session may be even more, because in the first 5 minutes, we have almost 55 participants with us. So I congratulate Dr. Nishkarsh Gupta, who is the academic coordinator for this. On this, I take an opportunity to thank all of you that for making our ISA Delhi YuvaCon 2024 a grand success, and that it was well attended by 428 delegates. Right, that was a huge number in past 3 years attending any ISA Delhi conference. That is there. It gives a good morale boost to all our organizers. And this recording sessions will be available on YouTube. I take a privilege to inform all of you that ISA Delhi is now having a YouTube channel, and soon it will be visible on other social media platforms like Twitter and Instagram as well. So I welcome you all to the second webinar series, and I really want to thank all my teachers and seniors who have agreed to be the teachers and the resource persons for this thing. So thank you very much for all of you to join us. Then I'll hand over to Dr. Abhijit Kumar, the treasurer, for welcome address.
Thank you, sir. Before starting, as Amit sir has said, we are really thankful to all the participants, faculties, and organizers for a successful conduct of ISA Delhi YuvaCon. At the same time, I would like to express my gratitude on behalf of ISA Delhi to our esteemed panelists and faculties who have agreed and spared their time to host and to teach in this webinar. Thank you so much. Thank you so much, Nishkarsh sir, for organizing all these things. I think without wasting time, we should go ahead with the academic session. Thank you so much, everyone.
Thank you, Abhijit. So we have divided this webinar today with a small talk on newer oral hypoglycemic drugs, as not a lot of drugs have come nowadays, and there is a challenge we face many times as anesthesiologists. So we'll start with the presentation first by Dr. Raghav Gupta, followed by the panel discussion. Raghav is a faculty with us at AIIMS Delhi. He is in NCI Jhajjar, and everybody knows him because he is very active on social media, and he's presently mostly all conferences he'll be presenting something. He's very active academically, and Raghav, we should please go ahead with the presentation.
Good evening, sir. Thank you so much. I hope my slide is visible.
Blank slide आ रही है राघव, कुछ दिख नहीं रहा है.
Sir, just.
कुछ नहीं दिख रहा.
Sir, just a minute, sir.
Maybe rejoin कर.
Just a minute, sir. I'll share screen.
अब दिख रहा है. अब उसको फुल स्क्रीन करो, फिर शायद हो जाएगा.
So is it fine now, sir?
नहीं, अभी फुल स्क्रीन व्यू नहीं दिख रहा. अभी आपके वो पूरा वो दिख रहा है, जितनी फाइल से सब दिख रहा है इसमें.
So just a minute, sir. Is it visible now, sir?
Raghav, it is visible, but it is not in full screen mode.
Raghav, start your presentation and make it in full screen presentation mode.
I did that, ma'am, actually.
Okay.
Shall I rejoin?
Raghav, it's better if you rejoin. Leave
yes,
and
sir,
rejoin.
Yes, sir, I'll rejoin, sir.
In the meantime, we can say good morning to all the panelists and our moderator, Dr. Sonia.
Yes, ma'am.
So I haven't heard of Sonia anywhere.
Good evening, sir. Good evening to all the esteemed panelists.
There comes the presentation.
Yes. So is it visible now, sir?
Now it is good, Dr. Raghav. We can start.
Extremely sorry for the technical delay. Very good evening to all the respected faculty members. So today I'll be talking on the topic neuro-oral hypoglycemic agents and the perioperative considerations. So first of all, this is the list of the oral hypoglycemic medications which are commonly used in a clinical practice, ranging from sulfonylureas, DPP-4 inhibitors, SGLT2 inhibitors, alpha-glucosidase inhibitors, biguanides, meglitinides, thiazolidinones, and GLP-1 receptor antagonists. So I'll be focusing my talk, I'll be discussing all these medications, but I'll be focusing my talk on the neuro-oral hypoglycemic medications in a little bit more details. Among the newer oral hypoglycemic agents, we are commonly using SGLT2 inhibitors, that is dapagliflozin and canagliflozin, DPP-4 inhibitors such as sitagliptin and vildagliptin, alpha-glucosidase inhibitors such as maglitol and voglibose. Then comes the thiazolidinones such as rosiglitazone and pioglitazone, and GLP-1 receptor antagonists such as liraglutide. So this is the schematic representation of the sites of action of glucose lowering drugs and their modes of action. So as you can see on the left hand side, acarbose is the one which decreases the glucose absorption. Biguanides is the one which decreases the glucose production, which further leads to decrease in the glucose, overall plasma glucose levels. And thiazolidinones increases the glucose uptake. SGLT2 inhibitors, which are the newer class of drugs, they decrease the tubular glucose reabsorption. Sulfonylureas and meglitinides, they increase the insulin secretion and decrease the glucagon secretion. And DPP-4 inhibitors increase the incretin levels. So this is one of the important schematic diagrams, and it gives a gist of the mechanism actions of the major newer oral hypoglycemic agents. So sulfonylureas, they are the ones which binds to potassium ATP channels in the beta cells of the pancreas, leading to inhibition of those channels. It further causes the influx of calcium and the stimulation of the insulin secretion. The common contraindications of the use of these drugs is the type 1 diabetes mellitus and the patients presenting with diabetic ketoacidosis. So what are the common anesthesia considerations? The risk of the hypoglycemia is very high with these agents. These agents can be taken a day before surgery, but they should be avoided on the day of the surgery. So these are the anesthesia considerations which we must remember with these agents, that the risk of hypoglycemia is very high, especially when they are given in combination with metformin. The chance of hypoglycemia becomes very high. Second class of the drugs is the DPP-4 inhibitors. They inhibit the enzyme dipeptidyl peptidase 4, which further inhibit the degradation of native GLP-1, and they further enhance the glucose-stimulated insulin secretions. So what are the anesthetic considerations? We have to reduce the dosage of these medications in the patients presenting with renal insufficiency, but these are the medications which can actually be taken on the day of the surgery. So that is one of the important differences compared to the sulfonylureas. Coming to the SGLT2 inhibitors, these are the newer class of agents, and examples are dapagliflozin and canagliflozin. They inhibit the sodium glucose co-transporter 2 in the proximal tubules of the renal glomeruli. It leads to inhibition of 90% of glucose reabsorption. It causes glycosuria in the people with diabetes and thus further lowering the plasma glucose levels. So these are the agents which are acting on the kidney, decreasing the absorption of the glucose. What are the important anesthetic considerations? There is the risk of urinary and genitourinary infections, polyuria, dehydration, and diabetic ketoacidosis. There are numerous guidelines on the continuation in the perioperative period, but the American Diabetic Association advises to withhold these medications at least 72 to 96 hours before this surgery. When a patient is using these medications and undergoes a surgery without interrupting the medication, ketones should be measured in the case of ketoacidosis, and treatment with insulin should be initiated by variable rate IV insulin infusion intraoperatively to control the ketone production. So this is one of the important take-home message with SGLT2 inhibitors, that patients are very prone to develop ketoacidosis. Coming to the fourth class of agents, that is the alpha-glucosidase inhibitors, they competitively inhibit the alpha-glucosidase enzymes in the intestinal brush water cells, which leads to inhibition of the polysaccharide reabsorption. It decreases the postprandial glucose levels, so taken just before the ingestion of first portion of the meal. That is important. What are the common adverse effects with these medications are the flatulence, diarrhea, abdominal pain, and these are all due to the mechanism of glucose fermentation. What are the anesthetic considerations? Risk of hypoglycemia is low in these medications. That is an advantage. And we have to omit the dose if meal is skipped and restart after the food intake is resumed. Coming to the fifth class of agents, that is the biguanides, they increase the hepatic AMP activated protein kinase activity. reduce the liver gluconeogenesis and lipogenesis, increase the insulin-mediated uptake of glucose in the muscles. They have a euglycemic effect rather than the hypoglycemic effect. That is an advantage with these medications, but there are a lot of adverse effects such as anorexia, nausea, vomiting, abdominal discomfort, diarrhea, and vitamin B12 deficiency, and also lactic acidosis, similar to metformin. So what are the anesthetic considerations? For one-day minor surgery, it is recommended to continue metformin except in patients with renal dysfunction or in the patients requiring interventions requiring a contrast medium administration, or in the cases in which we are going to use NSAIDs, or the patients already on ARBs or ACE inhibitors for hypertension. For major surgeries, it is recommended that metformin be stopped the day before the surgery. For both the scenarios, metformin should be resumed once the oral intake has been re-established and renal function is stabilized and normalized. Coming to the sixth class of drugs, that is the meglitinides. They act similar to sulfonylureas by regulating the potassium ATP channels in the pancreatic beta cells. They have a rapid onset and short duration action. That is an advantage with them. They have a minimal effect on overnight of fasting glucose levels. Administration is shortly done before the meals, but there are few adverse reactions such as hypoglycemia, but compared to sulfonylureas, it is still less. So that is an advantage with meglitinides. What are the anesthetic considerations? There is risk of hypoglycemia is there, can be taken day before surgery, but not to be taken on the day of surgery, and are contraindicated in patients with renal or liver failure. Coming to thiazidolidinones, they activate the peroxisome proliferator activated receptor gamma, that is PPAR gamma, which increase the insulin sensitivity in the patients and resultant peripheral uptake of glucose happens. They reduce the liver gluconeogenesis. They enhance the effectiveness of both the endogenous insulin production as well as the exogenous insulin if the patient is on. There are adverse effects such as weight gain, fluid retention. It may worsen or precipitate heart and GI disturbances. So these are few of the side effects with these medications. What are the anesthetic considerations? They can be taken day before surgery. They can be taken on the day of surgery if it is a minor surgery, but we have to hold in the case of major surgeries. Coming to GLP-1 receptor antagonists such as exenatide and liraglutide, they enhance the endogenous GLP-1 activity in the intestine. These agents increase the glucose-stimulated insulin secretion and suppress the glucagon secretion. What are the anesthetic considerations? They are slow the GI motility. So there are always the chances of vomiting and regurgitation happening, and chances of aspiration are high. For patients on daily dosing, consider holding these agents on the day of the procedure or surgery. For patients on weekly dosing of these medications, consider holding a week prior to the procedure or surgery. This suggestion is irrespective of the indication, whether they are being used as a medication for treatment of type 2 diabetes or weight loss dosage, or the type of procedure or surgery. So this is one of the summary slide and one of the important take-home messages for all the agents. It includes the older hypoglycemic agents also, but includes the newer hypoglycemic agents also. So sulfonylureas, meglitinides, biguanides, thiazidolidinones, alpha-glucosidase inhibitors, DPP-4 inhibitors, and SGLT2 inhibitors. These are few of the common medications which we are using in the patients, either as a monotherapy or a combination therapy. And as you can see from the chart, that in the case of ambulatory surgery, it is told that these medications can be continued a day before ambulatory surgery. In the emergency surgeries, you can see that all these medications have to be stopped. In the case of minor or major surgeries, there are few differences which I have already enumerated, but I'd like to summarize that sulfonylureas stop on the morning of the surgery and restart after the food intake is resumed. Similar, meglitinides also. In the case of biguanide, that is the metformin, restart after 24 hours with stabilized renal functions. Thiazidolidinones should be continued. Alpha-glucosidase inhibitors omit the dose if the meal is skipped and restart after the food intake is resumed. DPP-4 inhibitors, they should be continued. And SGLT2 inhibitors stop on the morning of the surgery and restart after the food intake is resumed. And generic names are provided in these in this table, so you can go through that. So what are the perioperative considerations? Diabetes should be well controlled prior to elective surgeries. We have to avoid insulin deficiency and anticipate the increased insulin requirements during the surgeries. Patient must be given clear-cut written instructions concerning the management of their OHA drug. This is one of the common mistakes which happens during the perioperative period, that patients are confused that what medications they have to stop and at what time period. Patients must not drive themselves to the hospital on the day of the surgery if it's a daycare procedures. Patients should ideally be kept on the morning list, preferably first. These guidelines may need to be individually modified depending upon the circumstances of the patients, and they should be kept well hydrated before the procedure. In conclusion, I would say that in case of scheduled surgical procedures, previous guidelines recommend to withhold the oral glucose lowering drugs, but based on the recent literature, this tendency has been shifted towards the treatment continuation. The continuation of these drugs seems safe, although it may be recommended to temporarily interrupt the treatment on the day of the surgery when the patient is fasting, or there is reduced food intake, or there is renal dysfunction is there. Inadvertent discontinuation may worsen the glycemic control, and inappropriate continuation also may induce hypoglycemia or ketoacidosis. Thank you.
Thank you, Raghav. So we'll have questions in the end. You can unshare the screen so that we can continue.
Yes, sir.
So now I invite Dr. Sonia Vadhavan. Ma'am is a director professor in Maulana Azad Medical College, my training place, and ma'am is very popular among students, and she is a very well-published academician, and a lot of bedside teaching she's also doing day in, day out, and that is the most commendable part. Ma'am, please introduce your panel. We'll be discussing about perioperative management of patient with diabetes. Over to you, ma'am.
Thank you so much. Very good evening to everybody. Thank you, Dr. Nishkash, for your kind words. And after such a very concise and informative talk by Dr. Raghav Gupta, and he's covered a lot of important points in the newer OHA. So we come to another interesting session of perioperative management of a patient with diabetes mellitus. And for this panel discussion, I have an esteemed group of panelists. Dr. Rakesh Kumar sir, he is a stalwart in anesthesiology, not only nationally, but an international fame. Sir has been an ex-director professor of anesthesiology at MAMC, MAMC, and presently he is the academic in charge of Dr. BSA Hospital, and he is the president of the Airway Management Foundation. He is also the force behind popularizing the ACLS, BLS, AHA accredited courses in Delhi and North India, and I've been very fortunate to be mentored by sir. Very warm welcome, sir. And I would like to invite Dr. Maitri Pandey, our next panelist. She is Director Professor and Head of Department, LHMC, New Delhi. Ma'am has a vast experience. She's a great academician, clinician, and she has organized several workshops and conferences and teaching programs for the graduates and postgraduate students in her institute, and has been a faculty nationally. Warm welcome to you, ma'am. Dr. Kavita Sharma, very dear friend and ex-director professor at Maulana Azad Medical College. She was our colleague, and now she is director professor at VMMC and associated Safdarjung Hospital. Dr. Kavita has a vast clinical experience, is a great teacher, a great mentor, and very popular amongst the students. I know she always adds interesting anecdotes in between her teaching sessions. Warm welcome to you. Dr. Purnima Dhar, a very senior anesthesiologist consultant at Apollo Hospital, Delhi. Madam has been, she's from All India Institute, and her vast clinical experience of managing years of various surgical patients, complex patients, and being an academician. We look forward to your inputs in the discussion, ma'am. And Dr. Yashdeep Gupta, it's very good to have an endocrinologist amongst us in the panel discussion. Without an endocrinologist or a physician, it is difficult to manage our diabetic patients very effectively in the perioperative period. He is working as an additional professor at All India Institute of Medical Sciences, New Delhi. So with this, I would like to start with the panel discussion. So why diabetes? It is one of the endocrinological diseases, but why diabetes? Reason being that India is already only second to China in the global diabetic epidemic, and the prevalence in India is about 9.3%. Approximately 25 to 50% of the diabetics undergo some or the other surgical procedure. So we know that the quantity of or the quantum of diabetic patients undergoing a surgical procedure is immense, sometime or the other in their lifespan. So keeping this in mind, my first question to Dr. Kavita Sharma, what is the criteria to diagnose a patient with diabetes mellitus?
Thank you, Dr. Sonia. As most of the postgraduates are listening, let's start with the basics. The first thing is the clinical signs and symptoms. Most of the symptoms are the common, what we say, polydipsia, polyuria, polyphagia. So because of a high glucose level, and there is a loss of glucose which is occurring in the urine. So because of that, the patients also become very hypovolemic. So there is a weight loss, fatigue, blurring of vision. These are the common symptoms by which they come. But as anesthesiologist, most of us will get patients who don't have symptoms, but somehow it is being diagnosed as a part of the routine investigations. So when we are investigating, if there is a blood sugar random level of around 200 milligram per deciliter, and along with that some symptoms are there, then we will call it as a diabetic. If the HbA1c is greater than 7%, or the fasting the plasma sugar levels are 126. If we talk about blood sugar, then it should be around 110, because students will find different values in the books. Like if it is a blood sugar, it is around 110, but plasma levels around 126 milligrams per deciliter. Or there is an impaired glucose tolerance. So that means at 2 hours, the plasma glucose is greater than 200. So then we will call this patient as a diabetic patient.
Thank you so much. So there are definitive blood investigations with their values, which help us diagnose a patient to be a diabetic or a person with a deranged sugar levels. So as we all know, diabetes may start anywhere in 30s, and nowadays it's coming even younger. And if it's type 1 diabetes, it is much earlier. So depending on the duration of diabetes, it is known to affect all the multiple organs because of its microvascular and macrovascular effects. So my next question is to Sir, Dr. Rakesh Sir. How does the micro and the macrovascular effects the perioperative patient care?
Thank you, Sonia. As you have already said, that it's a disease of the whole body and affects both the macro and micro circulation. But as far as the anesthesiologists are concerned, these patients will come to us with a nephropathy. They'll come with heart diseases, which can present in terms of ischemic heart disease or cardiomyopathies. Then they will have peripheral or autonomic neuropathies, retinopathies. These are the things they will come to us with. And the nephropathy normally will present in these patients in the form of swelling over the body, especially puffiness in the morning, the typical pictures of a nephropathy setting in. And they will be hypertensive on antihypertensive drugs, which will confound our perioperative management in these cases. And in these cases, here is, as Dr. Kavita has said, that sometimes we do not know that these are diabetic patients, but most of the times patients come to us who are already diagnosed as diabetic patients. So we have to look into the effect on the kidneys in terms of blood urea, creatinine, and electrolytes, irrespective of age of these patients. And if there are pictures which are showing that the clear-cut involvement of kidney, we may look for the microalbuminuria over 24-hour urine collection. On the other hand, the ischemic heart disease, the typical presentations are the unrelated to the age, angina or myocardial infarctions. They will have these events much earlier in their lives than others. And then, of course, dyspnea on exertion, poor exercise tolerance, METs less than 4, and then, of course, signs of heart failure if it is already there, like the typical pictures being edema feet, large liver, and so on. And again, irrespective of age, the clinical relevance is that all these patients must undergo an ECG and an X-ray chest in the preoperative period. Coming to the peripheral and autonomic neuropathy, the peripheral neuropathy can present like our case. I think we are talking about a case who has a foot ulcer or something in the foot. So they are very typical presentations that they will get infected, they will get trauma in the periphery because the sensory neuropathy has set in, and they can't make out when they are getting injured. They don't get the pain out there, or they are patients who have got dysesthesia or paresthesia, and they might be taking medications for pain control. And autonomic neuropathy, so these patients we will have to document their sensory changes which have occurred in these patients, so that if anything happens post-operatively, we are very sure that it is not due to the anesthetic management that we have undertaken. Autonomic neuropathy is very important to diagnose, and it comes in many features which are there. Usually gastroparesis, fullness of stomach, palpitations because of irregular pulse or resting tachycardias, or in the form of impotence or dyspareunias in female patients, or vaginal dryness. All these are indicative, or postural hypotension, blackouts. So these are the patients who will have to test them a little more. I am very fond of doing a bedside beat to beat variation test, wherein I ask the patient to take 5 or 6 slow breaths over 2 or 3 minutes, and then I look at the smallest heart rate, the fastest heart rate, and the slowest heart rate. And if the beat to beat variation is less than 5, they have clearly got autonomic neuropathy. There are special tests also, which I'll not go into details of. But the importance clinically is that all these patients who have either symptoms or signs or picture of autonomic involvement, they will be very prone to the sedative effects and the depressant effects of anesthetics and opioids. So we'll have to be very careful while giving them these drugs in the perioperative period.
Yes.
And coming last to the retinopathy, the retinopathy will again appear that 45-year-old person has already undergone a cataract surgery, or his vision has deteriorated. So, but the point is that if we are looking at all these, we are basically trying to gauge if the micro and macrovascular effect have been very significant or not, and then manage these patients perioperatively. The other things being the stiff joint and electrolyte imbalance, they are not dependent upon the micro and macrovascular involvement. They are dependent upon the glycosylation of the collagen. So that is what I think about it.
Yes. Thank you, sir. So you have very comprehensively touched all the salient features, which we should keep in mind when we are going to anesthetize a diabetic patient. Some of the things we are revealed to us during the investigations, but some of them we need to look for. So for all the postgraduate students, it is very important to be aware of all the systems that can be involved. And only when we are aware of something will we look for it. So my next question is to Dr. Maitri. Sir has already touched upon it briefly, but what is the importance of assessing the autonomic function in a diabetic patient? And could you discuss some of the commonly performed tests? What is the...
Good evening, Dr. Sonia and everyone. So autonomic dysfunction, to assess this is very important, because it affects the compensatory mechanisms of the cardiovascular system, and which may lead to increased hemodynamic instability in the perioperative period. And this may manifest in form of hypotension when there is a change in position, or when we are doing the induction of anesthesia, especially with propofol and thiopentone, and when we are instituting IPPV. And these may lead to, and there may be exaggerated hypotension with neuraxial blockade. So this we should, if we know about the autonomic dysfunction preoperatively, then we can take adequate measures for these, so that sudden hypotension doesn't occur in these patients. Other thing is that Dr. Rakesh just mentioned that these patients, the autonomic dysfunction may also affect the gastric motility, and it may lead to gastroparesis. So there is an increased risk of pulmonary aspiration of gastric contents. And these patients may also give history of resting tachycardia, early satiety, and postprandial fullness, and so on and so forth. So history is also important. When you are talking to this patient, we can just know by taking simple history that there's some autonomic dysfunction is there, and then we can carry out some simple tests. One is that the parasympathetic, for knowing about the dysfunction of the parasympathetic system, we look at the heart rate changes, and for the sympathetic system, we look at the blood pressure changes. For looking at the heart rate changes, we can do simple tests like just simple standing from supine position, or just Dr. Rakesh talked about the respiratory arrhythmia. So as we all know, when we are taking normal breaths, the heart rate decreases when during expiration and it increases during inspiration. This is a normal phenomena. And when there is autonomic dysfunction that the parasympathetic system is involved, then this difference is not there. So it can be done by monitor. You can see this if you are patient is being monitored, you can see this heart rate variability in your monitor. Otherwise, you can ask the patient to breathe quietly and deeply at the rate of 6 breaths per minute. And if the difference is more than 15 breaths per minute, then it is normal. And if it is less than 10, the difference in the heart rate, then it is abnormal. And second is that we can also test this when we can ask the patient to stand, and usually when we stand, then our heart rate increases to maintain the blood pressure. But if there is some problem with the autonomic, there is dysfunction, then this heart rate will not increase. So, and later on, there is relative bradycardia. So this is the heart rate increases at around 15 beat, and the bradycardia occurs at around 30th beat. So we can take the ratio of the longest RR interval and the shortest RR interval. And if it is more than 1.04, then it is normal. And if it is less than 1, then this is abnormal. And for the sympathetic nervous system, we can check the blood pressure, and we can ask the patient to stand, or it can be done by tilting the patient also from supine to almost erect. And this, if the systolic blood pressure decreases by more than 30 millimeters of mercury, or the diastolic decreases more than 10 millimeters of mercury, then it is abnormal. If it is, however, what is the normal decrease? There is some decrease. The normal decrease is less than 10 millimeters of mercury in the systolic blood pressure. And there are other tests also which we routinely do not do, that is Valsalva maneuver, sustained hand grip, etc.
Thank you so much, Dr. Maitri. You have covered most of the commonly done tests and what we need to see and how we need to interpret it, and the relevance you have already explained. So Dr. Raghav mentioned in his talk about the various oral hypoglycemic agents, plus some of the patients are put on insulin, there are various formulations for that. So Dr. Yashdeep, through this plethora of medications for glycemic control in a diabetic patient, how does one decide which one to start for whom, or what is the first line of medication? Then how do you proceed on from that? When do you switch over from a oral hypoglycemic to an insulin preparation, even for the non-operative patients?
So thanks, ma'am, for. So basically, till 2008, it was predominantly based on efficacy. So drugs were selected like how efficacious they were. Like now there is a recent change due to non-glycemic impact of these oral drugs. So like, for example, if the patient is having atherosclerotic cardiovascular disease, right, or patient is having CKD, then the drugs which have additional benefit beyond glycemia, like GLP-1 agonist or SGLT2 inhibitors, are become the first choice for these sort of patients, because they reduce the progression to macrovascular complication and reduce the progression to the end-stage renal disease. Then the another set of patients is like heart failure. If the patient is having diabetes and heart failure, then SGLT2 inhibitors are preferred, because again, they reduces the hospitalization and mortality from heart failure in a diabetic patient. Then comes your comorbidities or hypoglycemic potential. For example, if someone is obese, so we have to avoid drugs which can promote weight, like sulfonylurea or pioglitazone. And on the other hand, we should use drugs which can actually result in weight loss. For example, GLP-1 agonist followed by the SGLT2 inhibitors. Then there is a hypoglycemia. If the patient is prone to have hypoglycemia, then we have to avoid drugs which can result in hypoglycemia, like sulfonylurea, maglitinides, which were discussed in the presentation. But these are the choices which are actually made more commonly in a corporate setting. But when you are sitting in a public hospital setting, then it comes the cost and the availability in the pharmacy. So all that science goes down, and then what is available, and from that cost perspective, what patient can buy, it becomes this is another choice which dictates. For example, like in this case, the metformin, sulfonylureas, or gliptins, which are easily available, then become the first line drugs for these patients. So this is how we choose a patient depending upon affordability, the associated complications, the tendency of weight, what is an obesity part, and then hypoglycemia part, and the cost part. So these are the parameters which dictate drugs.
Now coming like role of insulin. So role of insulin, there are two main domains. For example, if someone comes with a catabolic symptoms, someone is already having advanced CKD, there is a hyperglycemia with having an infected diabetic foot. So such cases where euglycemia, achievement of euglycemia is very urgent, then the insulin becomes first line drugs like pregnancy, decay, and that sort of settings. But if it is a these settings are not present, then the ones who are like having OHA failures, which we define like typically not having euglycemia after using four different categories of drugs, then the patients are switched to insulin therapy. So this is how, like in brief, like we select a particular class of drugs for glycemic control.
Yes, so thank you so much, Dr. Yashdeep. So that's a very, you've given a broad sketch of how one starts the patients on oral hypoglycemic, or the ones who go on to the insulin regime. So taking on from here, what factors would influence the alteration of preoperative drug management in these patients? This question is for Dr. Purnima.
Yeah, so most of the basics have been covered by the previous with the previous questions.
Yes.
And for me, when a patient comes to the preoperative for preoperative checkup, a diabetic patient, in my mind, the first thing that comes to is that this patient's diabetes is going to get worse. Whatever the case, it is the blood sugars are going to go higher during the surgeries, especially if it is not a major, even if it's not a major, but even a intermediate kind of level of surgery. So therefore, if the patient's blood sugar is not controlled preoperatively, it becomes imperative that the patient is sent to a physician or an endocrinologist to get the blood sugars under control. And why is that?